Welcome to our deep dive on the course of depression in adults.
Yeah.
Um, this looks like a really fascinating topic, and we've got a ton of material here. It seems like you've been digging deep into the long-term picture of this really complex condition. We've got a bunch of research articles here, your own notes, ready to go.
Yeah.
So before we kind of get into all the twists and turns of depression's path, let's just step back for a second and make sure we're all on the same page of the types of depression we're even talking about.
Mm-hmm.
What are the key differences between, say, like a major depressive episode and something longer lasting?
Yeah, that's a great place to start. I think, it's really important to start with a clear understanding of the categories that we're talking about. And so we often talk about major depressive disorder and persistent depressive disorder, which you might remember used to be called dysthymia. And the DSM-5-TR, our diagnostic manual lays out very specific criteria for each of those. So if we think about major depressive disorder, that involves at least 1 2-week episode where there's a cluster of symptoms. So we think about, depressed mood most of the day, nearly every day, loss of interest in things that they usually enjoy, sleep troubles, fatigue, changes in appetite, or weight trouble, concentrating or making decisions, feelings of worthlessness or guilt, and even thoughts of death or suicide.
Mm.
And for a diagnosis, you need at least 5 of those symptoms, including either depressed mood or loss of interest.
Okay, so
So
5 or more, and one of them has to be either depressed mood or loss of interest.
exactly. And then persistent depressive disorder, as the name kind of implies, suggests, is really about this chronic low mood that lasts for at least 2 years in adults.
Oh, so it can be shorter in children.
Yeah, in kids and teens, it can be irritable mood, and it only needs to last a year. And then during that time, they'll experience at least 2 other symptoms of depression. So kind of a different time frame and a different set of criteria.
So we've got our kind of clinical definitions down.
Right.
But I think what I'm finding so fascinating in this material is the idea that, depression isn't just a static state, right? It's got a course, it's got a trajectory, it unfolds over time. And why is understanding this course so important, especially for us as general practitioners?
Yeah, it's a great question. I think
Yeah.
it's crucial because it really helps us to understand how to take care of our patients better. And I think that, the research shows us that the course can be really varied. So some people might have just one episode in their lifetime, and other people grapple with recurring episodes or even persistent symptoms that never fully go away. And
It's
so
not a one and done.
no, not at
Okay.
all.
In many cases.
And so that's going to influence everything from treatment decisions to long-term prognosis.
Right. Makes sense.
Okay.
Okay, so let's start with major depressive disorder. I'm seeing here in one of the studies that you flagged that recovery often takes around 20 weeks. But then I'm looking at some other data that indicate that some episodes resolve much faster, sometimes even within 8 weeks. So why such a big range?
Yeah, that's a question that I think researchers are still trying to figure out. So the 20-week figure that you mentioned represents a kind of average or a median across many, many studies, but individual experiences can differ dramatically. And it's true that some people do see very significant improvement within those first 8 weeks. And that's led to some interesting discussions about, what's the role of placebo effect, particularly in medication trials.
Oh, interesting.
There's still...
So some people are maybe just getting better on their own.
Or is it the expectation of getting better that's
Yeah.
actually leading to the improvement? So that's a whole other...
Can of worms.
Somber call of worms, exactly.
Yeah, fascinating. Okay, well, so this makes me think about all the different factors that could be influencing this recovery time.
Yeah.
I'm looking at your notes, and you've got, quite a list here. You've got severity of symptoms, whether psychotic features are present, anxiety levels, even childhood trauma. It seems like it's a real mix of kind of personal vulnerability and, life circumstances that all come into play.
Absolutely. Yeah, and the research does suggest that, on average, individuals with longer and more severe depressive episodes, especially those with psychotic features, tend to take longer to recover. Then you layer on comorbidities, things like anxiety disorders, personality disorders that can also complicate the picture, high levels of neuroticism or kind of that tendency to experience negative emotions, poor psychosocial functioning before the episode began, and then a history of childhood maltreatment is also associated with slower recovery.
And
So,
so really is this kind of perfect storm of factors that are all
exactly.
a lot of moving
Yep.
pieces there.
Yep.
Okay, so even when recovery does happen, it's not necessarily the end of the story. We need to talk about recurrence.
Yeah.
Because this is a big one.
We do. Unfortunately, major depressive disorder has a very high rate of recurrence, and in fact, the risk is highest in those first few months after recovery. So studies show that roughly half of those who recover from an episode will experience another one, And it seems like with each recurrence, the risk of having another episode goes up.
Oh, wow. So it's almost like
Yeah, it's not a,
it's kind of snowballing in a way.
yeah, it's unfortunately not a one and done situation for many people.
Yeah. So what makes someone more vulnerable to relapse? You mentioned residual symptoms being a red flag. What about other factors like age, personality, even just a general sense of control over one's life?
Yeah, you've hit on some key points there. So even mild lingering symptoms after an episode can significantly increase that risk of relapse. And we also see that a history of childhood maltreatment is linked to a higher chance of recurrence. Interestingly, research suggests that assessment and onset at a younger age, the presence of comorbid personality disorders, poor psychosocial functioning, and then a feeling of low mastery, which is essentially that perceived lack of control over life events, can all contribute to a higher likelihood of experiencing another depressive episode.
So it's kind of if you feel like you don't have control over your life, you're more likely to
It
have
seems to play a
episode.
role, yeah. And I think that makes sense intuitively, right? If you feel like things are happening to you and you don't have any
Right.
agency to change them, it can be
Yeah.
difficult to stay well. Yeah, and that's where I think our role as general practitioners becomes so crucial because we're often the first line of defense. We're the ones who can really, identify those early warning signs and intervene before things really escalate.
Absolutely. And, that makes a lot of sense, especially given what you've pointed out about just how variable the course of depression can be. But this brings up a question I often grapple with in practice. How do we actually define recovery in a way that's meaningful and useful?
Yeah.
I mean, we have those DSM criteria for, diagnosing the disorder, but pinpointing recovery seems so much less clear-cut.
Yeah, you've hit on a really important point. I think defining recovery from depression is not as simple as just checking off a list of symptoms.
Mm.
And so many studies use a definition that requires at least 2 consecutive months with minimal symptoms.
Mm.
So, no more than 1 or 2 mild ones. But crucially, they also look at psychosocial functioning. So it's not just about symptom reduction. It's about, can this person work? Can they engage in relationships? Can they participate in their life in a way that feels meaningful?
Right, so we're looking beyond just the checklist
Yeah,
and
exactly.
really getting into like how are they actually functioning.
Yeah, exactly. And as GPs, you're in a unique position to observe those subtle changes in functioning. Maybe it's at work, maybe it's in their interactions with their family, or just in their overall well-being. And that's invaluable information when you're trying to assess, is this person truly on the path to recovery?
Absolutely. I'm also noticing a theme in these research papers about the setting of this study and how that can influence the findings related to the course of depression. So, for example, individuals identified in community surveys might show a milder course than those being seen at specialized mental health clinics. Why would that be?
Yeah, that's a fascinating observation. And you're right, the research setting can make a big difference. So if you think about it, people participating in community surveys, they might have milder symptoms to begin with. They might be less likely to seek out specialized care. Whereas, individuals showing up at a tertiary care facility, they're likely dealing with much more severe or complex presentations. Maybe they have more comorbidities, greater functional impairment. And so it's not surprising that studies done in different settings would find different patterns in the course of depression.
All right, it's almost like we're comparing apples and oranges in some cases.
Exactly.
Okay, I'm seeing a similar point made about the differences between patients in routine clinical practice and then those who participate in these randomized controlled trials.
Yeah, right. So that's another layer of complexity. And it's important to remember that people enrolled in clinical trials are often a more select group. So they're usually recruited through very specific channels. They have to be willing to potentially receive a placebo, and they need to meet a whole host of inclusion and exclusion criteria, which are typical in industry-sponsored trials. So we might see lower rates of things like suicidality, psychosis, comorbidity, functional impairment in trial participants compared to the patients that we're seeing in our everyday practices.
Right, so again, it's sort of like, are we looking at the same population?
Exactly.
So as we're reading these research papers, it's important to keep in mind that the findings, may not perfectly reflect what we're seeing in our own clinics.
Exactly. We always have to apply those research findings within the context of our individual patients and their unique circumstances.
Absolutely. Okay, now one thing that really jumped out at me from this material is this concept of treatment-resistant depression. It sounds like a particularly challenging situation for both the patient and the clinician.
It absolutely is. And so when we talk about treatment-resistant depression, we're referring to cases where someone hasn't responded adequately to at least 2 different antidepressant medications. And we're talking about adequate doses given for a sufficient duration. And these are the individuals who often face a much more complicated and prolonged course of illness, and it can be incredibly frustrating for everyone involved.
And what are the implications of treatment resistance when we're thinking about relapse rates? Does it change the likelihood of someone experiencing another episode?
Unfortunately, research does suggest that relapse rates are higher in patients with treatment-resistant depression. One study that really sheds light on this is the STARD trial, which involved multiple sequential trials of different pharmacotherapy approaches. And the researchers found that the likelihood of relapse after achieving remission varied depending on which stage of treatment that remission occurred. So for those who went into remission with the initial treatment, the relapse rate was about 34%. But for those who needed a second step of treatment to achieve remission, the relapse rate jumped to 47%.
So basically, the more treatment steps it takes to get someone into remission, the higher the chance that they'll relapse.
That seems to be the pattern, and it really underscores the importance of close monitoring, ongoing support, and potentially more specialized interventions for individuals who are struggling with treatment-resistant depression. Getting those initial treatment choices right and personalizing the approach as much as possible could have a huge impact on those long-term outcomes.
Okay, so really setting people up for success in the very beginning.
Exactly.
Now, we can't have this conversation without acknowledging the very real impact that depression has on overall health and mortality. This is something that you've really highlighted in your notes.
Yeah, you're absolutely right. Depression is a major public health concern, and not just because of the toll that it takes on mental well-being. The research paints a pretty stark picture when it comes to the link between depression and mortality.
So can you elaborate on that a little bit? What do we know about the relationship between depression and mortality risk?
Yeah, so study after study has shown that all-cause mortality is significantly higher in individuals with depression compared to those without. And one large meta-analysis found that the risk of dying from any cause was about 50% higher in people with depression, even after taking into account other factors that could be influencing mortality, like age and physical health conditions.
Wow, that's a substantial increase.
It is, and I think what's particularly concerning is that this increased mortality risk isn't fully explained by co-occurring medical conditions. It seems that depression itself has an independent effect on overall health and longevity.
So it's not just that people with depression are more likely to have heart disease or diabetes.
Right.
It's that depression itself is a risk factor.
It seems to be a risk factor on its own.
Okay, are there any specific causes of death that are particularly elevated in people with depression?
Yeah. Sadly, suicide is a major concern. Major depressive disorder dramatically increases the risk of suicide, and it's considered one of the leading causes of suicide deaths worldwide. Research has also shown an increased risk of death from homicide and accidents in individuals with depression.
Wow, this is incredibly sobering.
Yeah.
It really underscores the urgency of, addressing depression effectively.
It does. I think we need to really view depression as a serious condition with potentially far-reaching consequences. Early diagnosis and treatment aren't just about, improving mental health. They're about potentially reducing those increased mortality risks.
Right, so it's about taking this holistic approach, understanding that managing depression requires us to consider the individual's unique circumstances, their risk factors, their long-term health prospects. It's about more than just treating those immediate symptoms. It's about supporting the whole person throughout their journey.
Absolutely. It's about recognizing that depression affects every aspect of a person's life, and our care needs to reflect that.
Absolutely. So let's talk practical application here. Knowing all of this about the complexity and potential severity of depression's course,
Yeah.
what are some key takeaways for us as general practitioners? What can we do day to day to really make a difference?
Yeah, I think, first and foremost, we can't skimp on those initial assessments. It's not just about, what are the symptoms right now? It's about really understanding the whole picture. So we need to be asking about past depressive episodes, what treatments have worked or haven't worked in the past, any family history of mental health conditions. And then it's crucial to really delve into that social history. So, any history of trauma, major life stressors, difficult relationships, all of that can really provide important context.
Yeah, it sounds like we need to really put on our detective hats and piece together all these different clues to get a sense of the individual's vulnerabilities and kind of their path to this point.
That's a great analogy. We're
Yeah.
gathering information, we're looking for patterns, and we're trying to understand what makes this person unique. And, beyond the questions, never underestimate the power of simply listening. Create that safe space for your patients to share their experiences, validate their struggles, and feel heard.
Right, that human connection, that sense of being understood can be so powerful, especially when someone is feeling really lost and overwhelmed by depression.
It can make all the difference. And then once we have a good grasp of the individual situation, we can start to think about a personalized treatment plan. And, this might involve medication, psychotherapy, lifestyle changes, social support. It really depends on the person and what they're going through.
Okay, so there's not a one-size-fits-all approach.
No, definitely not. It's about finding the right fit for each patient. And that often involves some trial and error.
Right, and trial and error can be tough for people
It can be.
who are feeling really depressed.
It can, and it's important to remember that, recovery isn't always linear. There will be ups and downs, there will be setbacks along the way. And so we need to be flexible and willing to adjust that treatment plan as needed.
I'm seeing from your notes here that there are quite a few different types of psychotherapy that can be helpful for depression. Can you give us a quick overview of what some of those options are?
Sure. So, cognitive behavioral therapy, or CBT, is often considered a first-line approach for depression. And it really helps people to identify and challenge those negative thought patterns and behaviors that contribute to feeling depressed. Interpersonal therapy, or IPT, is another effective option that really focuses on relationship issues and how those social dynamics might be playing a role in the depression. And then there are mindfulness-based therapies, which teach skills for staying present and managing difficult emotions. And psychodynamic therapy can be helpful for exploring, those deeper unconscious patterns that might be contributing to the depression.
So really a range of
A whole range of
number.
approaches.
Yeah. What about medication? When does that come into the picture?
Yeah, so antidepressant medications can be very effective for many people, especially when used in combination with therapy. But it's important to educate our patients about the potential side effects and the fact that it can take several weeks, even months, to see the full benefits of an antidepressant.
So patience is key.
Patience is key, both for us and for our patients.
Absolutely. We need to manage expectations and be open to, trying different medications or adjusting dosages if needed. And of course, we have to be vigilant in monitoring for any signs of worsening symptoms or increased suicidality.
Absolutely.
Speaking of red flags, you mentioned earlier that residual symptoms can signal a higher risk of relapse. What are some specific things that we should be looking for?
Yeah, so keep an eye out for, lingering low mood, even if it's not as severe as during the episode. Fatigue, sleep disturbances, trouble concentrating, changes in appetite or weight. These can all be kind of subtle signs that things aren't fully back on track. So even when someone appears to be doing well on the surface, we need to stay attuned to those subtler signs and, keep the lines of communication open.
Exactly. Encourage your patients to reach out if they notice any changes. And don't forget to involve family members or caregivers in the treatment process whenever possible. They can often provide really valuable support and be another set of eyes and ears.
Absolutely. This has been such an insightful deep dive. We've really explored the complexities of depression, the different types, the varied courses that it can take, and all those factors that influence recovery and recurrence. But what I'm taking away most from this conversation is just a renewed sense of how important our role is as general practitioners. We're often the first point of contact for people who are struggling with depression, and we have the power to make a real difference in their lives.
I couldn't agree more. It's about approaching each person with empathy, understanding, and a commitment to really walking alongside them on their path to wellness.
Well said. And a final thought for everyone listening. How can we as general practitioners better integrate mental and physical health care to really address the whole person and improve those long-term outcomes for our patients who are facing depression? Thanks for joining us on this deep dive.